Okay, I think we'll get started. So, hi everybody. I'm Raphael Hurst, Chair of the Department of Pediatrics here. I want to welcome you all to Pediatric Grand Rounds. Charisse, if you can you put up that first slide with the instructions? Great, thank you. So we are doing a webinar Zoom, which means that people have an opportunity. You won't be able to ask your question with your microphone, but if you do have questions during the course of the presentations today, please use the Q&A link to ask your questions, and we'll be collecting the questions and then asking them towards the end. And so with that, I'd like to turn it over to our Vice Chair for Medical Education, Sandrain Van Schaik, to introduce our speakers and to lead our grand round today. Sandrain.
Thank you, Rafi. It's an enormous pleasure to welcome our two speakers today. The first one of the two speakers for today is someone who I've known for quite a while and is probably known to a lot of us here at UCSF, Dr. Anda Kuo. She's a professor in the Department of Pediatrics and the co-director of the Cross Bay UCSF Center for Child and Community Health, and co-director of the CAACES Learning and Quality Improvement Collaborative. She is very passionate about leveraging the expertise we have at UCSF in partnership with multi-sector stakeholders to make child health and wellness a reality for all children. Dr. Kuo's professional roots are in medical education with a focus on leadership development of health professionals and health equity. And she is the founding director of the UCSF Plus residency program, which I think many of you know is a fantastic advocacy-oriented program, which has been recognized with the Academic Pediatric Association's Teaching Program Award in 2011. She co-founded the California Community Pediatrics and Advocacy Training Collaborative, which brings together 14 of the 17 pediatric training programs in the state of California and is now being modeled in 8 other states. She's an active member of the American Academy of Pediatrics, serving as a faculty mentor in the Young Physician Leadership Alliance as an evaluation consultant for the Community Pediatric Training Initiatives, Advocacy Collaboratives in the Carolinas and New Jersey. And she has had many awards, is a UCSF Academy of Medical Educators Chair in Pediatric Education, and one of our most beloved teachers and leaders in the department. Our other speaker, and I think they're going to give a presentation going back and forth, so it's not the first and the second, but they're doing this together, is a Professor Lisa Chamberlain, who is Professor of Pediatrics and the Arline and Pete Harmon Faculty Scholar and Associate Chair of Policy and Community in the Department of Pediatrics at Stanford University. Her focus is to improve the health and well-being of vulnerable children by performing health services research informing health policy, by redesigning pediatric primary care by bridging health and education sectors, and by training the next generation of pediatricians committed to reducing inequality. As the W.T. Grant Foundation's Distinguished Fellow, she spent significant time in Sacramento as Senator Richard Penn's health policy advisor from 2014 to 2016, where her health services research was used to reform California's Title V program. She founded the Stanford Pediatric Advocacy Track, a nationally replicated program that trains pediatricians to address child poverty through community and policy engagement, and that is now a national pediatric requirement. She co-founded the California Collaborative, which trains over 800 pediatricians a year, now modeled in 8 other states, as I mentioned in Anda's introduction. And she's a sought-after speaker. She gives keynote addresses, she has named lectureships, and has been a visiting professor at many locations. And today we're very excited that she's joining Anda. And with that, I am going to give it over to Anda and Lisa.
Great. Thank you so much, everyone. It's very weird. I wish I could see everyone.
I know.
But today I get to present with one of my long-standing collaborators and friends, and classic of our partnership. I suggested we invite her for Grand Rounds because she's doing amazing work in particular, some very interesting work down at the border. And she replied to the invitation that she would do it if I joined her. So that was before COVID-19, and so we'll have to have Lisa back to talk about some of the other amazing work she's doing. If you can advance, we have no disclosures. And today we want to articulate the variety of strategies of addressing the indirect impacts of COVID and explore the range of advocacy undertaken by pediatric generalists and subspecialists to address child health disparities, and provide institutional and individual tools to position ourselves to support the fourth mission of academic pediatrics. And you have to stay tuned for what that is. So we'll start with a case, and this is a case that Lisa happened to see down at the Gardner Clinic, but is one that resonates with patients we have seen as well at UCSF. It's a very young, premature baby seen at the 1-month checkup. And we've been being followed for poor feeding and not taking much by mouth. Had a complex medical stay and was seen by multiple specialists. And appointments had to be rescheduled, except for OT, which was continuing by phone during the COVID era. On exam, his weight was okay, and development was on track. And given all the complexities, the main thing that the parents were worried about was that Dad hadn't worked for 3 weeks. They were unable to pay rent. They were unable to find or buy basic items like diapers and only had enough formula for 3 weeks. And I think that resonates with a lot of us as we're seeing patients, some with very complex medical needs, and what's emerging as the biggest need for these families is often the social needs. So while the actual physical impact of COVID-19 infection, thankfully, is not targeting our pediatric population, we all know that the pandemic and the efforts required to control and mitigate COVID-19 infection is severely impacting children and families. And this UN policy brief was released recently on April 15th and really captures the tsunami that we all feel and fear, and for which we must prepare. Children are not the face of this pandemic, but they risk being among its biggest victims. All children of all ages and in all countries are being affected, in particular by the socioeconomic impacts. This is a universal crisis, and for some children, the impact will be lifelong. Moreover, the harmful effects of this pandemic will not be distributed equally. And we know that disasters, including this pandemic, have direct and indirect impacts. There's the direct impact of the COVID-19 infection, leading to hospitalizations, morbidities, and death, amongst other things. And then there's the indirect impacts, and this is what we're really focused on today when we talk about disparities. So the shelter in place has led to exposure risks that are different for different populations, unemployment, disruption of education, and a lack of basic needs for many people. And both in direct and indirect impacts, we are seeing disparities. So in the direct, there's disparities in testing, PPE, healthcare access and rationing, baseline comorbidities that had disparities to begin with, disparities in access to non-COVID care through telehealth and the fear presenting, especially for populations like our immigrant communities. And in the indirects, there's been disparities in exposures from people who are essential workers, people who are incarcerated or detained, people who live in multi-generational homes and are finding it hard to isolate. They're living in crowded, small living quarters, and amidst all of this is ongoing environmental racism. And on and on. What are we hearing from in San Francisco? And this was, as some of you know, a very interesting study that was done where the disparities are really highlighted. It's called the Unidos en Salud project, where they tested 3,000 residents and workers in the second most dense census tract in San Francisco, the Mission District. And as many of you know, this is a partnership between UCSF and the Latino Task Force for COVID-19 and the San Francisco Department of Public Health. And I'm really a big shout out to several of our PEDS faculty and staff who volunteered for that. What I want to highlight is that while 44% of the 3,000 tested identified as Latinx, 95% of the 62 positive PCRs were from individuals who identified as Latinx. And while 39% of those tested had an annual income of less than $50,000, 89% of the positive tests were people who came from that income bracket. And 90% of the 62 positives stated they were unable to work from home. And regarding pediatrics, according to the results available on the website, and highly recommend looking at it, of the 185 kids tested under 18, 6 were positive. Data is still emerging about the indirect effects of COVID-19, and so what we're hearing from our partners, like Katie Albright, who's the Executive Director of Safe and Sound, she emailed me really highlighting three buckets of family violence, family mental health, and basic needs emerging. So across the county, she said, we're hearing from our community partners about the indirect impacts. She said that days after school closed, child abuse reporting increased 50% in the Bay Area. Nationally, the reporting, decreased 50% in the Bay Area. And nationally, reporting has decreased 40 to 75%. In Los Angeles, for example, it has decreased by 75%. And the district attorney has reported that the Victim Services Division in his office initially saw a real bump in referrals for domestic violence victims by 60% in the first week of the shelter in place. And then by the next week and ongoing, the calls dropped, which has all of us and many advocates fearful, because we know that actual incidents are likely on the rise and that victims and survivors are afraid to call. Katie Albright also mentioned that there have been increased calls to parental warm lines. For example, San Diego has seen a 400% increase in their parental warm line calls. San Francisco Talk Line has also reported that all of the calls that are coming in are handling parental and caregiver anxiety, stress, and isolation. They also Safe and Sound did a quick needs assessment in these early shelter-in-place days and found that there's increased food insecurity, the shortage of basic needs, and housing insecurity were at the forefront, along with the inability to work. And this is worse based on immigration status. So the question is, who has eyes on our most vulnerable children? With schools and our primary care clinics and after-school programs and libraries closed, the most vulnerable children in our communities have lost their safety net. And I've been in communication, along with other faculty, with our public health nurses, and Michelle Salas is a supervisor in clinic, and supervisor of the public health nurses. And she shared that 2/3 of them have been deployed. So they have 440 cases that they're carrying across 10 public health nurses with an extensive waiting list. They normally carry a caseload of 25 each, and they're triaging who they see in person. So mostly they're doing things by telehealth. They're seeing profound increase in food insecurity, and they wanted to share that it's been incredibly helpful to have the access to the food pantries in 5M, which is our OB clinic and Family Health Center here at Zuckerberg San Francisco General. They also noticed that there are families with school-age children, and parents are really stressed because they are having trouble accessing technology, and they're having a hard time navigating all the assignments with the various platforms the teachers are using, and it's causing increased stress. And they have noticed that some families have given up completely. She also reports that when the shelter-in-place first started, many patients were engaged. However, they're seeing a drop-off now, and they're thinking that this is likely due to the inability to pay for phones and services. and also families and just slipping into depression and not really wanting to engage. They've also had to make reports based on concerns for domestic violence. She did want to say that as these issues have been arising, it's been really helpful that they have connections with our clinic units to be able to update the providers. And one thing, because I know people want, like, what can we do now? I don't know if this is something we can do right now, but if anyone has control over who has access to Epic, the public health nurses really have a very limited ability to see what we're seeing. And so they would really appreciate full access to Epic to be able to share their concerns and share the patients that they share with us. They only have CareLink access right now. They also said they've had 30 referrals for weight checks and that it's been going well, but their billing meter is broken. And so they would love access to a billing meter. And I think for us, that's an important function that they serve. So we're highlighting strategies that we've engaged with. And the social determinants of health have never been and continue to not be effectively addressed by a single entity. And the importance of mobilizing community partnerships is highlighted more than ever, perhaps. And fortunately, many of us in our department have really deep networks that can be rapidly triggered and accessed in times of crisis. And it really speaks to the importance of maintaining and nurturing these partnerships. Many of you have been engaged with us over the past few years with the convenings that we've had through the Center for Child and Community Health, formerly the Child Health Equity Institute, that we've facilitated with the Mayor's Office, the Department of Public Health, and First Five, and other groups from our more than 100 multi-sector stakeholders. And these are photos from when we were trying to create the shared goals, outcomes, and metrics of success that were going to guide the city for the next 10 years with our children, our families. How great would it be to be able to convene like that right now? As we rapidly navigate these new realities, these partnerships are critical, and I really think we need to leverage these partnerships even more to reach the families on the ground who need help. And so there's a lot of different considerations, like the 26 family resource centers in our city that are operating, 10 of them serving food and diaper banks, and how are there ways that we can leverage those connections and do campaigns like food and vaccines or something like that. In addition to our external partnerships, we know that our institution is a very complex organism with many arms moving and with a wide reach of children and families across our community that are often siloed. And I've been really grateful for the town halls and other infrastructure that our leaders have put in place to make sure we are collaborating and coordinating across our institution. Some of us in general and subspecialty pediatrics areas, including social workers and colleagues from the ER, across disciplines, across divisions and locations, have formed a social needs task force. We're meeting Thursdays every morning. And it's really to address the behavioral health, education, and social needs that are really rising to the top for many of our patients, especially those that are disproportionately impacted by COVID-19. And we're streamlining pediatric efforts and collaborating with key stakeholders to really identify what UCSF strengths and areas are to improve, to ensure that vulnerable families have access to the resources that'll bridge inequities. So we focused on big buckets of opportunities in policy, clinical resources and workflows, including like dot phrasing, and then community resources and stakeholder engagement. So here are some examples of mobilization, and this is mobilization for services for basic needs. And I am humbled every day and inspired by the individuals and the collective action that many of us are taking. I'm sure I don't know most of them. I hope we can harness that power even more. So to share a few, several of our colleagues reached out and helped me when my brother was stuck in Asia and was able to connect me with an FDA-approved manufacturer of N95 masks at cost. And you know, none of us, I think, thought we were going to be distributors of PPE or diapers, but that is what the need is. So Niti Doshi at Zuckerberg San Francisco General got our tech brother to post a fundraiser on Facebook, and we exceeded our goal within 24 hours and doubled it in 40 hours. So we were able to get 20,000 masks for $10,000, and we leveraged our partnerships. This is the photo that Matt Haney posted, Supervisor Matt Haney, who, by the way, is our AAP California CEO's Chris Calvin's son. I remember seeing him at our meetings, actually, when he was like studying in high school. So, you know, and he's been able to directly get the masks to people on the front line, literally getting texts from these folks saying, like, I'm crying. Thank you so much for remembering me. And I think it's hard for people who are really on the front line who may not be in the hospital, who are treating families who are homeless, et cetera, and they don't have the PPE. And secondly, ZSFG, as I've mentioned, has a patient pantry that is serving low-resource families throughout San Francisco, providing medical supplies, home goods, groceries, diapers. They've engaged UCSF student volunteers, neighbors, and local organizations, and have been able to supply over 8 clinical sites, 2 community centers, and over 100 patient homes. That's the email. They're literally collecting items and also accepting money donations. And a just quick shout out to Erica Lawson in the Division of Pediatric Rheumatology, who started foodrelief.us with her husband. It's a texting app where directly connecting people who need food immediately with restaurants who are providing free food. And one last tip I want to share is to, for those of us who can, avoid purchasing products that have the WIC label on it so that the shelves can stay stocked for families who need WIC. We're mobilizing around a very critical safety net that is absent in children's lives, at least not physically present, is the educational needs. And so a very quick example is early in April when the kindergarten registration enrollment was due. COVID had hit, shelter-in-place was in place, and the process is arduous and stressful at baseline. And during the shelter-in-place, families did not know about the deadline. They weren't clear how to enroll. They couldn't go to the Unified School District office, so you had to enroll via mail or this very complicated online system. And so a shout out to Amy Beck, Melanie Cowan, Eleanor Chung, Amy Whittle at ZSFG, who rallied many volunteers, medical students, and their friends and others and faculty. They attempted to call 442 families. They reached 290 families and really helped walk families through enrolling and understanding how to get online. So 50 submitted enrollment acceptance online while they're on the phone. And because of all the conversations with the Unified School District, maybe not because, but perhaps in part, the deadline was extended by a week. I mentioned a little bit about the mass and the disparities in mass. It's not just access to mass, but also in the experience of the mandate for mass. So there's a differential impact on Black communities in particular, with fear that's deeply embedded in racism and implicit biases. And something that many of us may not have even noticed is that the mass mandate includes imprisonment in its language. And some communities really fear that this is another policy that inadvertently or overtly sanctions imprisonment of people of color. And so I just want to highlight Chanel Williams, who's faculty with PTBI, and with support by other UCSF staff and faculty, authored a Democratic County Central Committee resolution acknowledging systemic racial inequities and calling for a coordinated response to support the Black community during the COVID-19 pandemic. Many UCSF faculty provided public comment to support. And in addition to the impact of the mandate, there's the disparities to access of reusable masks and the quick ramp up needed to be able to purchase masks and how that impacted communities differently. So I just want to highlight that in partnership with multiple stakeholders led by Bailey DeCastro from the Center for Child and Community Health in Oakland and BCHO, launched Project Mask, which is Mutual Aid and Safety Campaign for Oakland. It's a campaign that's fundraising for and procuring and rapidly distributing 30,000 reusable cloth face masks and public health information to vulnerable communities in Oakland. I just want to, another quick action item is our community partners here have expressed a need for usable masks for their communities. Like Coleman Advocates for Youth and 3rd Street Youth Center. So if anyone sews as a hobby or can rally sewers, please let me know, because the medical students tried to generate masks for them and weren't able to. Another area we're mobilizing around is around clinical standards, and these are examples provided by BCHSF social workers and the Division of Pediatric Rheumatology, who I think presented on this yesterday at the BCH San Francisco update. And they have tiered response screening questions and also response. And then the last dot phrasing is by Matt Pantel, who developed that with other stakeholders. And it includes a primer for introducing challenging topics to patients around social needs, and then screening questions with answer options, and then links to a living document of resources to address social needs. And really, this is about providing tools for healthcare workers and resources for patients, with a secondary goal of tracking the burden of social needs among our patients in a systematic way. Very classic of the Bay Area, there's lots of resources. It's really hard to sort through. People quickly went into action to create resource lists. And of course, there's not just one resource list, and that's something we're working on through the Social Needs Task Force. But these are QR codes that you can quickly take a photo of and access for Oakland's it's consolidated through the charliesclinic.org website, and then at CSFG, and also the BCH social worker resource list, as well as a medical student list, which has multiple languages. So I've walked you through some of the different strategies people in our department have been utilizing to mobilize during this time. And I really can't emphasize enough the importance of our partnerships across our institution and in the community in order to be impactful. And what I so appreciate about my partnership with Dr. Chamberlain is that I always learn something new, and she inspires me and challenges me to do things differently. And so I'm turning it over to you, Lisa, to share strategies that you've used at your institution and community.
Thank you, Wanda. Can you hear me all right?
Yeah.
Great. So yes, when Wanda invited me, I thought, oh, that would be so great. I can't wait to come up and see everyone. I did a general academic fellowship between UCSF and Stanford, and got to work with Tom Newman and Bob Pantel and Shannon Tyne and Amy Whittle, all sorts of fabulous people. So I couldn't wait to come up and see everyone. So this is certainly bittersweet, but I look forward to being able to come up and see you all in person and yeah, reconnect. That will be lovely. Meantime, why don't we come on down the peninsula? It's a aerial map. If you come on down, you can see the Dunbarton Bridge there, coming over to Stanford. And what you see here is the area of the Mid-Peninsula. It's a very dense urban area. It's where we practice. The places highlighted in red are the safety net clinics. These are the clinics that care for our Medi-Cal population, which, just like with you guys across the states, about 50–60% of our kids are cared for through this system. The Stanford Nursery is there with the Stanford logo. And the clinics that surround it are the San Mateo County Community Clinics, two of those, a federally qualified health center in East Palo Alto, Ravenswood, our continuity clinic, the academic medical center clinic at Gardner, and then a community clinic. So even though these clinics all have different bosses, so to speak, we all obviously report to the county, or we're our own FQHC or an academic center. We reached out to each other about 4 years ago and started working together. And it's an amazing group of faculty who have come together, and we talk about how we try to practice population pediatrics. So we work together. We call ourselves Impact, which is Mid-Peninsula Pediatric Advocacy Coalition. So you can see none of us went into marketing, but it's the best we could come up with. And we talk about what are the challenges that we see that our families have, and how, if we address them together, could we reach all of the kids? Because all of the kids in the Mid-Peninsula are born in our nursery at the Children's Hospital and then go to one of those 4 clinics for their care. So we really do have all the kids, particularly the 0 to 5-year-olds. We have a near 100% capture of our Medi-Cal kids. And so there's a real opportunity to reach everyone and through our partnership. So over the last few years, we started actually with food insecurity coming out of the Great Recession. We were very frustrated and made sure we were all screening with the same prompts, making sure it was all in our EHRs, partnering with our food bank, getting pantries in our clinics, so really mobilizing around that. We then moved on to think about early learning, the early childhood education space. 0 to 5 have implemented many different interventions in our waiting rooms so that we can try to reach those kids that aren't enrolled in preschool and who want to be kinder ready. And then also more recently frustrated around inability to access pediatric mental health. And so we all did the REACH training. So there's 35 new providers of mental health in our region. So this is the infrastructure on which COVID came. Once COVID came, we've been practicing together for a long time, and not only have we practiced with each other, we also have extensive community partnerships that we've been working with for many years. And so as soon as kind of the shelter in place came, we reached out, and so we've been having every other week calls for the last, oh my goodness, 3 months, 2-3 months, feels like a long time. And so these are some of our partners, and what we really heard from them was a real urgency to address what was happening in the community through those indirect impacts that Anda had mentioned. It basically came down to relieving economic burden of the families, the basic needs, the need for food, the need for diapers and formula were really the primary things. And it didn't take any time at all. It was probably 10 minutes into the first conversation, they said, don't forget about the fear of immigration. That's still going to be an issue. Even with families needing more, you're going to have to make your messaging very clear that what you're offering is going to be safe. And that is something that we're super aware of at baseline. But as we moved into this COVID space, I think it had drifted a little bit. So that was great to be reminded about that. And so our strategy right now that we've been working on is to supplement the needs for food in our core agencies, Samaritan House, Ecumenical Hunger Program. They're serving around 800 families a day, both of them, and they're running out of food each day. They do not have enough to meet the demand right now. And second, to providing diapers and formula, like that case, that child that I saw in clinic. So we're working to create baby bundles with diapers and formula to be in our clinics so that we can get them out. And then Head Start has asked if we can have food bags for the families. So those are the kind of 3 arms of what we're working on. And one of the first things was this flyer, the information that Anda mentioned, a real need to get the information out about what are the new resources in the community to address COVID, because a lot of new resources came to the fore once this started happening and continue to come in. And so we were drowning in resource options. We created this massive Excel spreadsheet of so many different resources. And then what we did is we took that to our community partners. We took the list to that community partner call and we said, help us organize this. Which are the ones that the community is going to need? Where are they located? How does it make most sense to get this information to our families? And so our community partners guided us, and I really want to give a shout out to Melanie Ramirez there in the bottom right, who so capably has led this initiative for us. And so we organized this flyer into food resources at the top in green, housing and emergency relief there, and then legal and immigration help at the bottom. All of it accessible either in a paper form or with the QR code. And we've worked with our social workers to turn it into dot phrases and have done this across 5 different counties now. But one thing that was interesting was that when we first had it, it's too dense. There's so much information on there, but we needed it in color, and to make copies in color was super expensive. So during one of our calls, the library said, oh, we'd be happy to make the copies for you, because the libraries at that time weren't allowed to have people inside. So in order to get these flyers into the hands of the people that we knew needed them, we went back to our community partners. And so we worked with the 2 adjacent school districts who are distributing thousands of meals each week, and took copies of this flyer to the meals distribution sites and literally put the flyers into the car with meals, in addition to leveraging our clinics, that clinic collaborative, and mailing it out to all of the clinic families. So you can see the envelopes there. After that, getting those basic needs met, the next thing our community partners asked for was educational resources. So a similar resource guide has been made, this time led by Jesus Pineda in our shop, and he has put together this resource, and it is being distributed in the same way through the school meal distribution program, and going to be mailed home through our clinics to all of the families. So again, we're just trying to come from a lot of different directions to make sure that our families get the information that they need. And so what can we learn from the past to prepare for this new future? We know from Katrina, we know from the Great Recession that there are going to be long-term impacts on our families in terms of how their families are functioning. We know that when there's parental disruption that we get, or parental stress, you have parenting disruption, and cycles continue. And so we, Anda and I are really committed to thinking about how does pediatrics need to respond. The field needs to be nimble, because the families that we're going to be taking care of after this COVID, because of what has happened with the pandemic, are going to have different needs. And so I'm going to turn it back over to Anda to talk about how the role of the pediatrician really needs to shift at this time. And a lot of that is through the power of collaboration.
Great, thanks. So one thing we want to highlight is that we have to shift, but in some ways, while these are unusual times, the role we're playing is not entirely new. And the need to find ways to collaborate with many different silos has been and continues to be, maybe more than ever right now, direly critical to our mission. So to remind ourselves, pediatricians and pediatric providers have always had a different role in the House of Medicine and Healthcare. And I always go back to this quote by Dr. Jacoby, who's thought to be the founding father of pediatrics in the United States, who said, "It's not enough, however, to work at the individual bedside in the hospital. In the near or dim future, the pediatrician is to sit in and control school boards, health departments, and legislatures. He is a legitimate advisor to the judge and the jury, and a seat for the physician in the councils of the republic is what the people have a right to demand." And so this is not, it could be a modern day Bay Area pediatrician who was raised in the 60s, but no, this was in 1904, and is really speaking to the roots of pediatrics. And if we remember that the AAP can be traced back to 1929 American Medical Association section on diseases of children meeting that was in Portland, Oregon, where ideological differences really became apparent and called for a separate medical organization focused on children. And as one of Lisa and my inspirations, faculty member down at Stanford, Paul Weiss, says, pediatricians are the ultimate witnesses to failed social policy. So we're shifting to really, we've been trying, we could spend this talk talking about what the disparities are, but I think we know the disparities are there, and we really wanted to focus on what we can do about it. We really learned about the power of collaboration when we launched with Gina Lewis at Benioff Children's Hospital, Oakland, the first pediatric statewide advocacy and community pediatrics collaborative in 2007. And a group of us in Northern California have been working together with others, sharing training curriculum, literally in Lisa's living room when she was here at San Francisco. And at UCSF, and we thought, this could be bigger. So we went Bay Area first, and California Endowment funded that, and then they funded us to go statewide. And ultimately, we had, that's where all the little stars are, 14 of the 17 pediatric training programs in California. And we focused on two areas. One was community pediatrics training resources and sharing curricula and training. And we also developed a shared legislative advocacy curriculum, ultimately training 900 residents a year, and continue to do so. In one of the side benefits, I guess I would say, that came out in the publication that we had in Academic Medicine that highlighted what the impact of the collaborative was that on faculty, there was this sense of cohesion and a sense of purpose and community that is now being looked at other collaboratives in other states, and how that impacts burnout. This is a photo that we had. Luckily, you can't see me or Lisa that well because we might look a little different. That was in Hawaii at the PAS meeting. It just really shows, I think, you know, initially, honestly, reaching across is hard. There's a lot of barriers, academic and institutional barriers, but we are all really one big happy family now. And our power has really collectively shown up in our advocacy role. And pediatricians have always been, and pediatrics has always been a trusted voice to the public and our policymakers. And the power of our patient stories is really priceless to legislators. So in California, we've had this very close partnership with the American Academy of Pediatrics chapters, and that's been a very powerful connection. We've developed a process where the academic centers and other training sites bring their residents to Sacramento once a year. So it used to be that like 7 residents would come up from one institution and maybe 3 the other, but since, over a decade, we've been bringing 50 to 100 residents to Sacramento during the CMA legislative day, and really powerfully speaking for children, and really showing when we work together, we can cross market share and academic lines and make an impact. We have one example of this is Senator Richard Pan, former residency program director at Davis, who has been working tirelessly to advance immunization legislation for kids. And in 2015, he introduced AB 2109, and it was so eye-opening for all of us, and especially our trainees, because there was this massive number of anti-vaccine campaigners who were really angry at us. And we filed in like 100 doctors with their white coats. We were spilling out into the hallway. They had to have us like in this backup upstairs room. And we all went in front and testified about the importance of vaccines and how they save lives and how important it is for kids. And what was great is that it just crossed divisions, and it was not about our bottom line, but it was really based on science. And basically, once we were done, the hearing was over and the bill passed. And that was where parents who elect to sign a personal belief waiver for immunization exemptions have to have a conversation with the healthcare provider prior to signing. Lisa and I have been very active with the National AAP, and especially through its Community Pediatrics Training Initiative. And based on the California model, the AAP has been supporting similar models in other states. And Lisa has coached 4 training programs, for example, in Missouri. North and South Carolina also has created this dual state collaborative called the Carolinas Collaborative. I've been partnered with them. They have 8 training programs across both states to evaluate the impact of the collaboration on its faculty. We have been in the midst of writing a manuscript on the mitigating effects we're finding on participation in collaboration, on mitigating burnout and bolstering resilience. And the states are doing the same thing we did here. They're training pediatricians in community pediatrics and advocacy, and partnering with communities and testifying on behalf of children and advocating. So the vision is that by 2022, we will have 114 of the 198 training programs in the U.S., so close to half, and engaged in statewide collaboratives and regional collaboratives. The beauty of the collaborative is that over 10 years later, we're still engaged. The funding's long gone, but we're still active and bringing 50 to 100 residents to Sacramento every year and collaborating around really critical issues like SCHIP, where SCHIP reauthorization, we launched nationally simultaneous rallies with pediatric residents And now with COVID, we're collaborating around advocacy training and clinical care. So Dr. Kobe's vision of the role of pediatrics is embedded in academic pediatrics, and increasingly there are calls for academic pediatrics and medicine to formally institutionalize our role in eliminating health disparities. And you can see there have been several articles about this. And how do we incorporate the social determinants of health in our tripartite mission as a fourth pillar, or the quadripartite mission? Try saying that 3 times fast. So it's education, research, clinical care, and social accountability. How do we get there? This article in Academic Medicine recently in February of last year articulates a path. So there are currently 151 academic health centers in the United States. And as a group, they really disproportionately have contributed significantly to improving the health status of vulnerable communities, and a huge number of trainees. So what's great is the fourth mission, quadripartite mission of social accountability, integrates the triple threat of research, education, and clinical care with the triple aim of better care, better population health, and lower per capita costs. And the 3 steps that are identified in this framework are the identification of priority health needs and challenges, which requires community partnerships, the adaptation of the tripartite mission to those priority health needs and challenges, and having a rigorous assessment of the impact of academic health centers' efforts in this regard. It also highlighted really that the critical of structured community partnerships and identifiable responsible leadership of the social accountability mission. I'm going to, in the interest of time, Lisa, I'll go a little quickly through this, but these are examples of the different levels of how we can support the infrastructure for this quadripartite mission. So at the department level, infrastructure for community engaged research. We have some infrastructure that has been built here with Emily Von Shaven at her UCSF Child and Adolescent Chronic Illness Center, and also with the Transforming Research as Usual for Equity program that we have that was with Coleman Advocates for Youth, and the co-PI was Meggie Yakamura. And basically our Community Advisory Board identified over 100 priority research questions, and they refused to whittle those down. So we created 7 priority research themes from those areas, and they're listed here. The Community Advisory Board also developed family research training modules that are accessible and available to people. They're in English and Spanish and available online, and really can be used for other community advisory boards and parent advocacy trainings, for example. So in addition to community partnerships, another key step to the quadripartite mission is the formalization of community advisory boards and a departmental role to support these efforts.
All right.
I'm going to pass it to Lisa.
Thank you. So I am going to talk about the department role. Those are beautiful photos, and I love seeing that. So just want to tell you a little bit about how we've tried to move towards that kind of 4-legged model down here. This is a previous structure, kind of typical structure, I think, for a Department of Pediatrics. You have associate chairs, you have the chair, and then associate chairs of education, research, and clinical care. And the evolving structure that we have embraced over the last couple of years is to add a fourth, and that is the Associate Chair of Policy and Community Engagement. And so I've been in that role now for about 1.5 years, and it's been really fun to try to think of how to define this and how to do this work. And I know that there's a lot of movement up there in terms of and commitments, obviously with all the amazing community engaged work you guys are doing to have similar roles. In terms of our department structure and how we're addressing policy, I kind of see it as 3 different areas where we're trying to move this into our culture. One is at the departmental level, one is at the division level, and the other is at the level of the individual career paths of our junior faculty. So there's a few different strategies that we're using We're engaging in a social media strategy, one that also addresses legislative and regulatory involvement. And then finally, just raising awareness across our institution, across the entire enterprise, so both hospitals, Adult and Children's Hospital, and all of our faculty around these issues, around issues of social determinants and community engagement as they impact our families. So I'm going to kind of show you what it looks like a little bit. At the departmental level, we do a lot of different things. We go to town hall meetings. The picture on the left is they're one of our residents speaking at Anna Eshu's town hall meeting. She's our representative in Washington, thanking her for being a friend to children, and then you know, asking her pertinent questions about how to move things forward. I don't know about you, but now in post-COVID eyes, I look at that room and I'm like, oh, everything looks so different now. Like, don't want to touch anyone. That was a while ago, so don't worry. The middle picture is the SCHIP rally, or sorry, Medicaid rally. Anda had mentioned that we had done a rally for CHIP years ago, and this was more recently, a couple of summers ago in June, when we were kind of caught off guard and surprised that Medicaid was in the crosshairs, so to speak, and so participated with the American Academy of Pediatrics in a nationwide rally to support Medicaid, and that was in fun partnership with all of you up at UCSF, and California represented very well. We mobilized our collaborative, and all the training programs in California participated in that social media storm. And then we have, if you see on the far right, that is Anna Eshu giving grand rounds at Stanford. We invite elected officials once a year to give grand rounds to give us a state of the children. It's one of our highest attended grand rounds every year, and it gives us an opportunity to make more connections with our elected officials, and also really learn from them and talk about the importance of understanding how what happens in Washington and Sacramento comes into our families' lives and really impacts them. And then we're always engaging with the media, training our residents and our faculty to say yes to those requests in order to advocate for kids. So I want to take just a minute and talk about the power of social media. This is a newer tool in our toolbox to articulate the passion that we have for kids, and want to tell the "This is our lane" story. Many of you may have heard it and not totally grasped it, so it's a quick one. So hashtag "This is our lane" started when the NRA posted this story, or this tweet. "Someone should tell the self-important anti-gun doctors to stay in their lane. Half the articles in the Annals of Internal Medicine are pushing for gun control. Most upsetting, however, the medical community seems to have consulted no one but themselves." So that was posted, and you can see the time and date there at 11:43 in the morning on November 7th. And they put that picture in there. I did not, that was their tweet. And pretty quickly after, Dr. Joseph Sarkin tweeted back, "As a trauma surgeon, and as a survivor of gun violence, I cannot believe the audacity of the NRA to make such a divisive statement. We take care of these patients every day. Where are you when I'm having to tell those families their loved one has died?" And that set off a storm. Things started to get posted like this: "Can't post a patient's photo, so this is a selfie. Stay in my lane. Good morning, just a reminder, this is my lane. She didn't make it." So there were countless responses, mostly from our emergency room physician colleagues, trauma surgeons. Pediatrics did get involved, but it became deafening. There was a huge frustration from physicians to be able to talk about the impact that these policies have on our families. And so an open letter was written, and over 42,000 physicians signed it. What's important about this story, I think it highlights a couple things. One, this is really a powerful media that does reach a lot of people, to the point where it crossed over into traditional media. And so this really was a way to say, this is another side of the story. This is clearly the way that a lot of our policy conversations are happening these days, is through social media. And so I think the opportunity for physicians to become involved, for pediatricians to come involved, to talk about what we're seeing with COVID, to talk about what's happening to our families that don't have enough food, like that kid that I saw from the NICU. It's an important opportunity for us to bear witness and show support for the policies that we know our families need. So that's the "This is our lane" story. But beyond that, we've been working here to kind of try to take some of this to our different divisions. So this is a picture of our pediatric GI division. They were interested in getting some training around social engagement, so you can see some of them here, their tweets, learning how to leverage social media advocacy efforts, something that one of them tweeted about, and then there's a picture of them on the right after we had one of our sessions, and they created their own. Not only did they make individual accounts, but their division has an account now where they're tweeting about things that are frustrating to them and where they see disparities for their patients. And as part of the process here in this role that I have, I've been going and talking to different divisions to hear where are the disparities coming in your division? Where when you have patients, one that's privately insured versus one that's on Medi-Cal, what's different? What's frustrating? And I tell you what, I get into these division meetings and it just starts coming forward. Whether it's, and you can see they're different issues for different clinical specialties. GI is very frustrated. They feel there's a lot of disparities in organ allocation, other things around continuous glucose monitoring. So there's a wide range of issues that are generating disparities in these subspecialties, and the solution to those are policy. The solution to those are working with our government relations folks and our American Academy of Pediatrics and the other subspecialty academies to elevate these issues and look for policy solutions. So thinking about how we can all work as a coherent group here to advocate for our families through the lens of our subspecialty is one thing we're working on, in addition to being unified kind of in the central circle there, to have this policy response team when there's something big and overarching like Medicaid or issues at the border, things we all care about, we can take action on that together as well. So coming down from the division level to the individual level, I think it's really important that the junior faculty, say in those pictures from GI, are interested in engaging in advocacy. There needs to be a career path for that. There needs to be an opportunity for their work to be quantified and described and evaluated by our A&P Appointments and Promotions Committee here for consideration in moving through academic ranks. And so we are working with our A&P committee using this article that I was happy to be involved with about the advocacy portfolio. So it describes a standardized tool for documenting physician advocacy, because as I'm working with these junior faculty and helping them to coordinate and hone their advocacy voice, I need to make sure that they have, that it's contributing to their academic development. So that's been super fun to think about and start to move forward down here. So just want to close with this idea that, you know, Anda and I have been working together for so many years and really do see the power of us working together, the power of us coming together, because we share the responsibility to take care of the kids in the Bay Area. They are all of our kids. And I think now more than ever, we are going to have to come together to take care of the impact of COVID, which the reverberations of which I think we are going to see for many, many years. And she and I share this dream that one day we'll be going down the 101 and this will be the billboard. Instead of it being Packard or UCSF, Benioff, that there's one that says Packard and Benioff, Children's Hospitals Unite, that no child will go hungry, or no child will go without mental health support, or whatever our issue is, that there's such an opportunity for our powerful and deeply respected institutions to come together to start to tackle some of these problems between all of our clinical outreach and all of our reputation. I think that we could have a very powerful and unique voice in fighting for the kids of the Bay Area. So that's just literally the billboard that she and I have been talking about for many years. It was fun to put that slide together. So just want to close and leave the slide up for you here, some more opportunities for ways for you to get involved, whether it's clinically, you know, leveraging some of the amazing resources that have been put together for your families, getting on Twitter. There's our Twitter handles. You can follow us and get engaged in the conversation. Other ways to support some basic needs and or get involved by rolling up your sleeves and volunteering. So hope that this has been a talk that has helped you think about how you can get engaged, and thank you very much again for the invitation to come and talk with you all.
Thanks, Lisa.
Thank
There
you
was
both very much. Anda, did you want to say?
No, I was just going to read that there's one question.
Yes, there's actually, and one question. We are at 1 o'clock, and I want to be respectful of everyone's time. So I'm going to suggest that we're going to follow up on that question outside of the format of grand rounds, and I'm handing it over to Dr. Hirsch to say a final word. Before I give it to him, thank you. This was very, very fantastic work, and that billboard, yes, looks good to me.
Well, thank you. I want to add my thanks to Anda Quo and Lisa Chamberlain for an outstanding presentation, and also for your advocacy and leadership on behalf of the children of the communities that we serve. And I really love the vision that you presented. So thank you. This was wonderful. And I'd like to wish everybody well and enjoy the rest of your day. Thank you.
Thank you.